Module 11, Respiratory Care, Acute Care Nurse Assistant. Content 1, Basic Terminology, Terminology and Clinical Setting Application. Module 2, Basic Anatomy and Physiology of the Respiratory System, Purpose and Function of the Upper and Lower Respiratory Tract. Upper Respiratory Tract, the nose, the throat or the pharynx, voice box, larynx, windpipe, trachea. Lower Respiratory Tract, alveoli, intercostal muscles, bronchi, lungs, diaphragm, mediastinum, and pleura. Lung clearance mechanisms. Content 3. Factors that affect our ability to breathe. Age, positioning, elevated temperature, exercise, drugs and medications, obesity, emotions and pain, immobility, and smoking. Content 4. Abnormal signs and symptoms of the respiratory system and the role of the nurse assistant. Abnormal signs and symptoms. Labored respirations, such as respiratory distress, shortness of breath, dyspnea, noisy respirations, wheezing, fast and slow respiratory rate, change in the ability to perform or tolerate ADLs, shallow respirations, dyspnea on exertion, hypoxia, sputum, increased production, changes in color of sputum, and specimen collection. Cyanosis, change in the color of skin, especially the lips, fingertips, and mucous membranes. Hemoptysis. Role of the nurse assistant. Report any signs or symptoms of labored breathing or respiratory distress immediately to the licensed nurse. Shortness of breath may be chronic, a problem for a patient, or a new symptom. If shortness of breath is a new symptom, report immediately to the licensed nurse. If it's a chronic symptom, group care activities to allow the patient to rest between activities. Use calm, slow movements around the patient to help relieve anxiety. Position patient in erect sitting position or leaning forward on overbed table. Wheezing can signal increasing respiratory difficulty, a buildup of fluid in the lungs, or an allergic reaction. If it is a new or worsening symptom, report immediately to the licensed nurse. Respiratory rates above or below normal should be reported immediately to a licensed nurse. Monitor the patient for changes in color of skin, anxiety, confusion, behavioral changes, and fatigue. Changes in respiration or conditions of the lungs can make a patient have difficulty in performing normal ADLs. Even if the patient does not have any respiratory difficulty, always monitor the patient's ability to perform normal activity and observe for fatigue and shortness of breath. Report any changes to a licensed nurse. Observe patient not only for number of respirations per minute, but the depth of the respirations and symmetry. Encourage patient to deep breathe to assist in clearing lung secretions and prevent hypostatic pneumonia. If the patient becomes short of breath with activity, allow extra time for ADLs and speak with a slow, calm voice to prevent causing anxiety. If this is a new symptom, report to licensed nurse. Many things can cause inadequate oxygenation. Some signs to observe for include pale, cold, clammy skin, bluish color around the lips and fingertips. Report any of these symptoms to the licensed nurse. Hemoptysis is spitting up of blood. Use standard care precautions when cleaning up sputum. Report any signs of blood-tinged sputum to a licensed nurse. Content 5. Common disorders of the respiratory system. Chronic obstructive pulmonary disease, or COPD, bronchitis, asthma, emphysema, pneumonia, tuberculosis, pulmonary embolism, upper respiratory infection, and sleep apnea. Review age-related issues. The nurse assistant's role in preventing or minimizing respiratory complications. Resource personnel are respiratory therapists, licensed nurse, etc. Content 6. Patient positioning for maximum lung expansion. Patient positioning: pulled up, sitting in bed, semi-high Fowlers. Use of pillows. Use of bedside table across bed. Sitting at side of bed, leaning on overbed table. Maximum lung expansion in elderly. Content 7. How to assist the patient with procedures that improve breathing. Purpose: prevention of atelectasis, which is a collapsed airless condition of the lung alveoli. It is prevented by deep breathing, movement, and pain relief. Procedures: using the incentive spirometer. Turn, cough, and deep breathe. Positioning. Activity: out of bed, ambulation, splinting, cough blanket and cough pillow. And mouth care. Content 8. The role of the nurse assistant in teaching the respiratory patient. Reinforced teaching is directed by licensed personnel. Incentive spirometer, turn, cough, deep breathe, and positioning. Activity: out of bed, ambulating. Splinting, cough blanket, cough pillow, universal, standard precautions. Refer to Module 4. Content 9. Equipment used in the care of the respiratory patient and related role of the nurse assistant. Pulse oximeter. 2 light sources and a photodetector sense the color changes in hemoglobin when placed directly across from each other. The probe placement. Most common placement is on the finger, but can be placed over the earlobe, toe, bridge of nose, and foot or palm of baby. Do not place over fingernail with dark polish or artificial nail. Change sites each day and check for pressure points under the probe. Hospital policy. The licensed nurse or respiratory therapist is responsible for monitoring the pulse oximetry measurements. However, they are very easy to read, and you can recognize changes that need to be reported to the licensed nurse. Reporting the results: normal and abnormal. All values should be reported to the nurse. Many facilities rate the value below 92% as abnormal, but be sure to check with your licensed nurse and your facility policy. Troubleshooting for accuracy. Patients with poor circulation, dark pigmentation, very low blood count, such as anemia, will often have inaccurate readings. Vigorous movement by the patient will also cause misleading numbers. Chest tube, tubing, and canister. Check tubing for kinks and prevent patient from laying on it. Patient may be positioned in most positions of comfort. Keep offside where the chest tube is inserted. TCDB every 2 hours is important when a chest tube is in place. The patient may ambulate if ordered by the physician. Check with the licensed nurse and make sure the canister remains below the level of the chest. Do not allow the chest tube canister to fall over. The licensed nurse will calculate the output in the chest tube canister. Observe for any of the following signs and report them to a licensed nurse: complaints of pain, shortness of breath, change in vital signs, increased apprehension in the patient, draining on the dressing at the chest tube insertion site, or a loose chest tube. Content 10. Common tests or procedures performed for determining the cause or status of a respiratory problem. Purpose of tests: identify the cause or status of respiratory problems. Give the doctor information for proper treatment and/or medication. Respiratory tests: pulmonary function test, bronchoscopy, arterial blood gases, chest X-ray, thoracentesis, sputum CNS, and pulse oximetry. Limitations of the nurse assistant's role: cannot perform sterile procedures. Acts as a second pair of hands for the licensed nurse or MD under their direct instruction and supervision. Cannot perform any invasive procedure. Content 11. The use of oxygen and equipment for administering oxygen. The oxygen tank is placed in a rack or secured in a cylinder cart. Can become a deadly missile should a valve be broken off. Close the cylinder valves before moving cylinders. Do not store near electrical circuits. Do not open the cylinder valves with wrenches or pliers. Always open the valve before turning on the flow meter. Always close the valve and then turn off the flow meter to release the pressure in the regulator. Oxygen supports combustion. Materials that are combustible and flammable in the air will ignite more easily and will burn more vigorously in an oxygen-rich atmosphere. Materials that are not normally considered to be combustible in air may be considered combustible in an oxygen-enriched atmosphere. Some combustible materials may be found near a patient receiving oxygen, such as oils, Vaseline, skin lotions, facial tissue, clothing, bed linen, rubber and plastic articles, suction and oxygen tubing, alcohol, and acetone. Anything that can spark and create a fire around oxygen, such as smoking, electrical heaters, defibrillator, defective electrical equipment. Nasal cannula, a simple two-pronged plastic device that is used to deliver low concentrations of oxygen and allows the patient to eat and talk normally. Place a nasal prong into each nair of the nose and adjust straps of the oxygen tubing over the ears and under the chin. Some patients like to have gauze padding wrapped around the tubing that goes over the ears. Check the cannula regularly for clogging or crusting. Clean only with a damp rag and do not use alcohol or soap water. Change the cannula if clogged or badly soiled. Observe the nairs of the nose and ears for sores and report immediately to a licensed nurse. Content 11. The use of oxygen and equipment for administering oxygen. Simple. Used for low to moderate oxygen concentrations, should not press too tightly on the face, as this may cause a feeling of claustrophobia. Non-rebreathing. Used for higher concentrations of oxygen, but cannot be used for controlled oxygen concentrations, and must be adjusted for proper fit. Bags on partial and non-rebreather masks must remain inflated during both inspiration and expiration. This is accomplished by adjusting the flow so that the bag does not collapse on inspiration. Check with your respiratory therapist when transporting patients and changing from wall oxygen to portable oxygen. Venturi mask or venti mask allows delivery of precise oxygen flow. A constant flow of room air is blended with fixed oxygen to provide diluted oxygen and precise low amounts to the patient. Care guidelines. Adjustable elastic bands are provided that fit over the head to secure the mask and must be checked frequently for pressure areas. Face masks need to fit securely, and skin under mask must be checked frequently for irritation. Mask must be removed so that the patient may eat, drink, or take medications. May reapply nasal cannula and mask when O2 already turned on, and set at proper liter flow by licensed nurse or respiratory therapist. If oxygen is ordered PRN, may reapply after patient returns from activity, such as the bathroom, eating, or ambulating. If oxygen is ordered continuously, reapply when mask or cannula slips off face. Tracheostomy. The definition is a surgically created opening through the neck into the trachea. The protective upper airway is bypassed, causing greater risk for infection. It also allows water to flow directly into the lungs if accidentally spilled over the trach area, such as when bathing or when the patient is drinking. Care guidelines. The nurse assistant never changes the ties or the inner cannula. Some facilities may allow nurse assistants to suction secretions external to the cannula and clean the outer stoma. Refer to facility policy. Ambu bag to face mask. Ventilating bag attached to the mask that can deliver oxygen. It gives a good seal and provides a barrier for standard precautions. It is used in emergencies as part of CPR. Check facility policy for nurse assistants' role in using the ambu bag and training before it is used. Incentive spirometer. Promotes full expansion of the lungs and prevents pulmonary complications. The patient exhales through the nose and then inhales through the mouthpiece on the incentive spirometer. Use of the IS is based on the learning theory that immediate objective feedback increases motivation to learn and results in quicker learning. The IS is quite effective, and most patients do more deep breathing using them. Flow meter, a device that attaches to the oxygen outlet to adjust the amount of oxygen being delivered. They register the amount of oxygen being delivered in liters per minute. There are two types: mercury, ball and gauge. Humidifier, container of sterile water usually pre-filled that is attached to the oxygen delivery equipment. Liquefies lung secretions to keep them loose and facilitates expectoration. Oxygen flows through the water and picks up moisture. Water must be sterile to prevent infections. Changed when the water level is low or according to the facility policy. Many facilities change the humidifier every 24 hours. Some facilities are only using humidifiers for oxygen delivery of over 2 liters. Resource personnel are the respiratory therapist and the licensed nurse. Safety issues. Oxygen is not explosive but does support combustion. There should be no smoking around any oxygen and the delivery system. Inspect all electrical equipment for defective plugs or frayed cords that could cause a spark. The patient cannot use any electrical equipment around oxygen, such as radios or electric razors. Avoid wool blankets as they cause static electricity. Content 12. Basic care for patients receiving oxygen therapy. Feeding a patient on oxygen therapy. Allow time to breathe between bites. Check for orders to remove oxygen for meals. Keep food off the tubing. Clean the nasal cannula by wiping with a damp cloth only, and do not use alcohol or soap and water. Nasal cannula prongs and masks must be positioned properly. Use secured straps. Check ears for irritation under the tubing. Make sure there's no kinks in the tubing, and know the different types of oxygen masks. Nurse assistant's role. May not initiate oxygen therapy. Learn about changing oxygen tanks and changing to portable oxygen when transporting a patient. Safety measures. No smoking around oxygen. All electrical equipment must be grounded. Observe for signs and symptoms of respiratory distress. See Objective 4 in this unit. Content 13. Proper procedure for oral suctioning. Purpose and procedure. Role of the nurse assistant. The nurse assistant cannot suction airways. Suction is limited to oral cavity only. Nurse assistants can use suction to prevent aspiration of fluids used in performing oral care. Each healthcare facility may have different guidelines regarding restrictions for nurse assistants in suctioning procedure. Refer to nurse assistant's job description and facility policy and procedures. Module 11. Basic Anatomy and Physiology of the Respiratory System. Normal anatomy and physiology of the respiratory system. For the millions of cells throughout the body to carry out their specialized activities, they must have a continuous supply of oxygen. The respiratory system works with the cardiovascular system to deliver oxygen to the cells, where it is used to provide the cells with energy to carry out metabolism. External respiration, or breathing, allows the exchange of oxygen and carbon dioxide between the lungs and the environment. As air is inhaled, it is warmed, moistened, and filtered to prepare it for use by the body. Internal respiration refers to the exchange of oxygen and carbon dioxide at the cellular level. Oxygen enters the cells, while carbon dioxide leaves the cells. These gases diffuse, they move or spread across the cell membranes into the bloodstream. The cardiovascular system plays a role of a transporter. Failure of the respiratory or cardiovascular systems has the same result: rapid death of the cells from oxygen starvation. The upper respiratory tract. The nose. Air enters the respiratory tract through the nose. It is filtered, moistened, and warmed as it is entered. The nasal sputum separates the nares. The entire area is lined with mucous membranes which are filled with blood vessels. This provides the warmth and moisture necessary. Normally, a liter of moisture is secreted by these membranes every day. This is the area that causes problems with sinus infections or colds. The patient is unable to warm or moisten the inspired air. To the sides of the nasal cavities are 3 scroll-like bones called the turbinates, or conchae. These cause the air to move over a large surface area. The increase in surface area allows the air more time for warming and moisturizing. Lining the nasal cavities are tiny hairs, which trap dust and other foreign particles and prevent them from entering the lower respiratory tract. The sinuses are hollow, which make the skull lighter. It is believed they give resonance to the voice. They are also lined with mucous membranes that are continuous with the nasal cavity. Because of this, nasal infections can cause sinusitis, which is uncomfortable and difficult to treat. The receptor for the sense of smell is located in the mucous membranes of the nasal cavities. The tear ducts have openings to the upper nasal chamber, so when a person cries, nasal secretions are increased. Pharynx, another name for the throat. It's approximately 5 inches long and is the passageway for both air and food. At the end of the pharynx, food passes into the esophagus. The pharynx is divided into 3 subdivisions: the nasopharynx, the oropharynx, and the laryngopharynx. The eustachian tubes enter both sides of the nasopharynx, connected to the middle ear. Because the inner linings of the pharynx and the eustachian tubes are continuous, an infection of the pharynx can easily spread to the middle ear. This is very common in children. The larynx, or the voice box, connects the pharynx and the trachea. The epiglottis, a large leaf-shaped area of cartilage, protects the larynx when swallowing. It covers the larynx tightly to prevent food from entering the trachea and directs the food to the esophagus. The larynx contains the vocal cords. Trachea, or windpipe. It's a tube-like structure that extends approximately 5 inches into the mid-chest, where it divides into the right and left bronchi. It lies in front of the esophagus and connects the larynx with the bronchi. It contains C-shaped rings of cartilage that keep it from collapsing. The open part of the C-shape lies to the back of the tracheal column and in front of the esophagus. This allows for expansion of the esophagus during swallowing, while still keeping the trachea open for uninterrupted breathing. The whole structure is lined with mucous membranes, with tiny cilia that sweep dust or debris upward toward the nasal cavity. Any large particles in this area trigger the cough reflex, which is a protective mechanism that aids in the removal of foreign materials. If a tracheostomy, a surgical opening in the trachea, must be performed, the individual breathes through the tracheal opening rather than the nose. The opening is below the larynx, so the air cannot pass over the vocal cords. The vocal cords cannot vibrate, and speech becomes physiologically impossible. The air does not pass through the upper airways to be moistened, which creates the drying of secretions, and mucus forms plugs that block the airways. A patient with a tracheostomy must constantly be aware of moisturizing the air and clearing the airway. Lower respiratory tract. Bronchial tree. As the trachea enters the lungs, it divides into the right and left bronchi. The right bronchus enters into the right lung. It's larger in diameter and more vertical in descent. The left bronchus enters the left lung. It is smaller in diameter and slightly horizontal in position. Because of this design, foreign objects that are aspirated often enter the right bronchus. Bronchioles. The large bronchi continue to divide into smaller structures called bronchioles. It has been estimated that there are more than 1 million bronchioles in each lung, all about 1 millimeter in diameter. These structures continue to divide into smaller tube-like structures called terminal bronchioles or alveolar ducts. The branching and continual division of the tubules make these structures resemble a tree with branches, hence the name bronchial tree. All of these structures are lined with ciliated mucous membranes, as is the trachea. Alveoli. These sac-like structures at the end of the bronchial tree resemble a bunch of grapes. A single grape-like structure is called an alveolus. It is the terminal structure of the bronchial tree that gas exchange takes place. Each alveolus is surrounded by a blood capillary. Carbon dioxide and oxygen are exchanged across the alveolar capillary membrane. Each alveolus is composed of hundreds to thousands of alveoli, contained in alveolar sacs. The walls of the individual alveoli are comprised of a single layer of cells with elastic fibers that are intertwined. This enables them to contract and relax with breathing. In addition, each alveolus is coated with a thin covering of surfactant. This is a lipoprotein that reduces the surface tension of the alveolus and prevents it from collapsing and sticking together between each breath. There are millions of alveoli in the lung that give the shape and the form to the lungs. They're filled with air, and the lung tissue would float if submerged in water. This tiny grape-like structure is the most important feature of the respiratory system. Capillaries. In the cardiovascular system, the vessels get smaller and smaller until they reach the smallest structure called a capillary. This is microscopic. In the lungs, these capillaries surround the alveoli. Because the walls of the capillaries are thin, and the walls of the alveoli are also thin, diffusion allows the oxygen to pass from the alveoli into the capillaries in an exchange for carbon dioxide. Once the oxygen enters the capillaries, it attaches itself to the red blood cells, more specifically, the hemoglobin portion of the red blood cells. The oxygen then continues in the bloodstream to the heart to be transported to the cells throughout the body. Inhaled air always contains small pieces of matter and microorganisms. These substances do not usually create problems because the lungs have an excellent set of mechanisms for clearing unwanted material. Filtration in the nose. The nose contains hairs that serve as filters to filter out large dust particles. The effectiveness of the filtering mechanism becomes apparent when a lot of dust is in the air. Mucus production. Mucus is secreted by glands in the membranes throughout the respiratory system. Small particles are trapped in the mucus. Mucus both protects the tissue from the particle and provides a medium for removal. Ciliary clearance. Tiny cilia throughout the bronchial tree are continuously active in moving mucus toward the upper airway. Smoke paralyzes cilia in the lungs, making lung clearance more difficult. Cilia may also be damaged by disease processes. Macrophages. There are no cilia in the alveoli. Instead, macrophages surround particles to remove and destroy them. These particles are disposed of through the lymphatic system. The mucus then moves to an area where cough may effectively remove it. Position changes. When the position of the body is changed, mucus, with its small pieces of matter, moves in the lungs as a result of the gravity. Because of the branching nature of the lungs, almost any position will cause some lung segments to drain. As the position is changed, different segments are able to drain. Cough. Coughing is a mechanism to protect the lungs from aspiration of foreign material in the upper airway, and to clear material from the lower airway. For the most productive cough to occur, there is deep inspiration. The glottis is closed, expiratory muscles contract forcefully, building up pressure in the chest. Then the glottis is opened, expelling material from the airway. Cough may be caused by stimulation of the receptors in the upper airway, the trachea and pharynx, or those in the lower airway, the larynx and bronchi. Irritant gases such as smoke, fluids, touch, and particles in the air may stimulate these receptors. The huff cough is like a regular cough except that it is done with the glottis open. High pressures are not achieved in the chest, but it appears that this type of cough facilitates peripheral airway clearance. The quad cough was developed for the use of quadriplegic patients. The quad cough is used to assist an individual with weak or ineffective muscle action. When the person coughs, the nurse applies pressure with the hand on the abdomen with an upward and inward motion, thus increasing the pressure for expulsion of secretions. Normal aging changes in the respiratory system. Lungs comprise the organ of the body that, in addition to the skin, is most exposed to the environment. Smoke, bacteria, and multiple irritants are inhaled daily for many years. The elderly frequently have other diseases that may affect lung function. For these reasons, it is very difficult to differentiate the effects of environment and disease from the effects of aging. Although the function of the pulmonary system decreases with age, the loss involves the reserve necessary during stress. The losses are not great enough to interfere with ordinary activity. And even this decrease in reserve can be kept to a minimum if elderly people actively maintain fitness. Anatomical changes with aging. Skeletal deformities of aging, such as kyphosis, cause the thorax to become shorter and the anterior-posterior, front-to-back diameter to increase. This results in less space for the lungs to expand and decrease lung volume. Osteoporosis of the ribs and vertebrae and calcification of the costal cartilage contribute to chest wall stiffness. This stiffness produces a decline in the ability of the chest wall to expand and contract normally with each breath. Chest wall muscles, such as the diaphragm, intercostal muscles, and accessory muscles, like other muscles in the body, weaken with age. This combination of increased stiffness of the chest wall and diminished muscular strength reduces the efficiency of breathing, so that the aged have reduced maximal inspiratory and expiratory force. More muscle work is needed to move air in and out of the lung. Within the lung structures themselves are other significant changes that are taking place. At age 20, a person has about 300 million alveoli, which provide an exchange surface of 80 square meters, about the size of a tennis court. The number of alveoli remain constant in the healthy aging person, but there are changes in the alveoli. The alveoli enlarge, the walls become thinner, and there are fewer capillaries present. This loss of alveolar structure gives aged lungs some microscopic characteristics of emphysematous lungs and is sometimes called senile lung. Thus, the effective alveolar surface area that is vital to gas exchange is reduced to 65 to 70 square meters by the age of 70. Because of the following changes, the elderly are less able to provide adequate force to move air rapidly. Decreased lung volume, chest wall stiffness, weaker chest wall muscles, loss of elasticity of the lungs, and reduced alveolar surface area for gas exchange. The work of breathing is increased so that the elderly tend to make greater use of all respiratory muscles, especially the diaphragm. This increased reliance on the diaphragm makes the elderly more sensitive to changes in pressure within the abdomen, such as after a large meal or the body position of bending over to tie the shoes. Functional changes. Functional changes refer to changes in the volume of the air moved as occur with aging. Although total lung volume remains fairly constant, age influences the different measurements of this volume. The following is a list of pulmonary function tests that are done to measure lung volumes. Tidal volume is one of the most significant lung volumes for nursing care and is the amount of air moved with a normal breath. Dead space is the portion of air that moves through the mouth through the terminal bronchioles. It is not in contact with the alveoli and therefore does not participate in gas exchange. The amount of dead space in the lung is approximately equal to an individual's weight in pounds. Thus, if a person weighs 200 pounds, about 200 cc's of tidal volume is dead space ventilation. Tidal volume, which can be very simply measured with a spirometer, should be relatively unchanged in the aged. Minute ventilation, the amount of air moved within 1 minute. There are conflicting reports on changes in respiratory rates with age in adults, but it appears there is very little, if any, significant effect from aging on normal subjects. Residual volume, the volume of air that remains in the lung after maximal expiration. It increases with age, probably because of the loss of elastic forces in the lungs. This increased residual volume encroaches on and reduces vital capacity. Vital capacity, maximum amount of air that can be breathed out after breathing in as much as possible. Studies have shown that vital capacity decreases 25% in the aged, while residual volume increases about 50%. The reduction in vital capacity is thought to be largely related to the loss of chest wall mobility. Airflow rates, the rate at which air is moved in and out of the lungs, is reduced in the elderly. The amount of air individuals can breathe in and out as rapidly as possible in a given period of time declines by 50% from the 3rd to the 9th decades. Even in a healthy, aged person, the lungs have some of the features of chronic obstructive lung disease. Decrease in airflow and trapping of air in lungs. There is a collapse of the airways on expiration, with trapping of gas in the lungs and a decrease of the flow of air. The small airways are less stable, especially when smaller breaths are taken, as happens with the elderly. This early airway closure increases with age and with shallow breathing. It may also be increased in the supine position. A practical application of nursing care of this knowledge of airway closure is a reinforcement of the need to encourage deep breathing in the elderly and to keep them out of bed as much as possible. Gas exchange, changes in the elderly. As mentioned earlier, the alveoli enlarge, the walls become thinner, and there are fewer capillaries present, making less surface area for gas exchange. There is also age-related reduction in the amount of hemoglobin, which is necessary to carry oxygen. Functional changes. Diminished response to low oxygen levels. There is a decreased response to hypoxia and hypercarbia. This has great clinical significance for nurses and nursing assistants. The usual clinical signs of increased need for oxygen include increases in breathing rate and volume, an increase in heart rate and blood pressure. These responses are all slower and blunted in the elderly. Therefore, additional cues such as changes in mentation, such as the decreased ability to concentrate or confusion, and affect, behavior such as anxiety, sadness, fear, and irritation, must be used to detect and prevent complications of lack of oxygen or high CO2 levels. Protective function of the lungs decrease with age. The cough mechanism is impaired in the elderly due to weakened muscles. Less effective ciliary action and fewer cilia leads to decreased in the ability to clean and protect the lung. A decrease in IgA. This is a protein of the immune system that protects the nasal and respiratory mucosal surfaces from harmful bacteria and viruses. The fourth factor is a defective activity of alveolar macrophages. They are present in the alveoli and decrease with age. This factor affects smokers especially. Nurse assistants' role in preventing or minimizing respiratory complications. Encourage coughing and deep breathing. Reinforce the use of the incentive spirometer. Hydration and nutrition. Offer fluids every 2 hours is allowed to keep lung secretions thin. Assist with activity and early ambulation. Positioning. Change position and turn bedridden patients at least every 2 hours. Identify and report signs and symptoms of oxygen deficiency or malfunction of oxygen delivery equipment. Identify and report signs and symptoms of infection. Use good observational skills. Identify and report signs and symptoms of pain, and institute comfort measures. Measure and record intake and output accurately. Encourage self-care, and reinforce patient-family teaching. Nursing care to minimize the effects of aging. Position for maximum lung expansion. Patients must be kept pulled up in bed. When a patient slides down in bed, the chest wall becomes compressed and lungs cannot expand fully. For patients sitting up in a Fowler's position, placing pillows under the arms to support the extremities allows for greater lung expansion. In a side-lying position, placing the upper arm on a pillow along the patient's back allows for better chest wall expansion than curling both arms around the pillow to the chest. Patients in wheelchairs and jerry chairs must be kept pulled up to prevent collapse of the upper chest. Placing pillows to support the upper trunk will help maintain maximum lung expansion. Some patients with respiratory disease prefer to sit at the bedside or in a chair, or lean over a bed table. Make sure that the wheels are locked on the bed or wheelchair and place a pillow on the table for the patient to rest the arms and head. This allows for better expansion of the chest wall. Normal breathing must be promoted. Encourage the patient to take deep breaths frequently and to stand up straight as possible when walking. If the patient is in bed most of the day, turning, repositioning, and deep breathing will help mobilize secretions in the lung. Heavy bed linens can compromise the normal expansion of the chest in a patient who is weak and has complications of an illness or aging. Keep heavy bed linens off the chest. Some patients will cover themselves with favorite afghans and multiple blankets. Use warm, lightweight linen, like thermal blankets provided in most facilities, instead of multiple layers of a sheet, blanket, or bedspread. Keep the patient as active as possible. It is common knowledge that there is a decrease in exercise tolerance in the elderly. They have increased heart and respiratory rates with minimal exercise. Studies are being done that indicate that aged athletes who participate in endurance training can lower their heart rates and breathlessness created by exertion. This shows that even though we cannot modify age, we can modify fitness by exercise and activity. In the elderly, it is more important not to aggravate physical limitations by inactivity. Oxygen equipment, incentive spirometer, oxygen setup, the O2 tank, flow meter, humidifier, nasal cannula, and face mask. There are various types. Chest tube, tubing and canister, and pulse oximeter. Criteria: demonstrate patient positioning for maximum lung expansion. Demonstrate how to assist the patient with the following: the incentive spirometer, turn, cough, and deep breathe. Positioning: coughing with splinting, cough blanket, cough pillow, and mouth care. Demonstrate the use and care of the following equipment: incentive spirometer, changing the O2 tank, the flow meter, the humidifier, the nasal cannula, the face mask, such as a simple, venti, or non-rebreather, chest tubing, tubing and canister, do not empty or do not clamp, and the pulse oximeter. Thank you for your attention.